to start with يعني أرجو إنك تعذروني لو في مشاكل في النت. لأن الفيديوز ممكن تكون تقيلة شوية في الأبلود، أنت عارفين النت بعافية شوية. And I don't know if we have people who are not speaking Arabic in our group here. يعني يعني not to mix Arabic words with English. I'm afraid if we have some who doesn't understand, doesn't speak Arabic. ولا إيه يا دكتور؟
أعتقد كله بيعرف، يعني ما فيش حد أجنبي.
Okay. Uh, when we speak about the POCUS in ICU daily round, we speak about something that I personally believe that it's mandatory in the critical care round. Uh, and I'm going to show you, without a lot of talking about the evidence, which is huge in the literature. If you just write POCUS in ICU, point of care in emergency, point of care ultrasound in here or there, you find hundreds of cases, of literature to give you the strong evidence, research-wise, to support whatever in the point of care ultrasound need to be supported by literature. So, but my aim tonight is not to take it to the dilemma of argument, but to show you the real life how it goes. Because some people, when you talk to them about the point of care ultrasound, they will mention the disadvantages of ultrasound in general, and they would say it is unfortunately operator dependent, or unfortunately it's not this, not that. No. In some cases, I'm gonna show you some of these cases. Every day, you see evidence from the real life that point of care ultrasound changes totally, and I mean totally, the plan of care from this direction to that direction. Uh, and you're gonna be surprised that once you put the probe, you have a question in mind, and you know where to put your probe, then you might discover something that might be not at all in your brain when you think of what is the differential diagnosis of this patient presentation. Without further ado, let me go with the first case here. It's written case number 4 because I just catched the cases from different presentations before. This is obese lady, around 45-year-old, post-pediatric surgery. She was on the floor, day 3 post-surgery. When she was previously in the last 3 days post-surgery, she was fine. All of a sudden started to have epigastric pain. She started to vomit. While attempt to go to bathroom, she collapsed on the floor. Fainted, blood pressure is 80/50, though her usual blood pressure is 130s, and heart rate increased significantly, dramatically to 145 when the RRT team, the rapid response team, attempt to see her in the floor. And her saturation was dropped. She was cyanosed. In room air, the saturation was only 80%. Of course, tachypneic, showing a severe respiratory distress. Day 3, post-surgery. What could be the differential diagnosis? I'm sure if I open the mic للناس كلها, everyone and one of these votes will be that we are dealing with what? Probably somebody who's obese, post-surgery, now shocked and hypoxic. Female, above 40. Everything is pointing toward the PE as a top list of differential diagnosis. And our team actually, when heard about this case, and we attempt to go to the ward to see her with the announcement of rapid response team, we heard of the history. Everyone is going and prepared to deal with a PE, and thrombolysis is immediately indicated. Point of care, when it's used, we put the probe first in the abdomen. This is when you see a picture like this, you are using which probe? This is phased array probe or abdominal probe, curvilinear abdominal probe. This is curvilinear abdominal probe. The probe of choice when you try to see the abdomen, because it's a low frequency probe, the penetration power of this type of probe in the abdomen of obese patients is very high, or at least we say it high penetration power. So you can go cross the skin, bed of fat in the subcutaneous, and then you go to the abdomen and you discover what is there. This is post-abdomen surgery. And what you see here, the probe is put on the upper, in the mid-axillary line, 8th intercostal space, 8th, 9th, and 10th. On the right side, you see the liver here, and part of the kidney is probably seen here, but there is fluid around above the liver here, maybe encircling the liver. This fluid is not hypoechoic, but you can see clearly inside this area of hypoechoic shadowing, indicating fluid in the abdomen. You see dots, white dots, hyperechoic dots, which indicates either pus, infected materials, or blood in the abdomen. When the probe was moved anteriorly, you see here, the bottom screen, you see fluid with the same threads and dots, which indicates we are dealing with free fluid in the abdomen, which looks like turbid fluid. So we don't know yet what's going on. Patient is shocked and severely respiratory distressed, hypoxic. The echo has to be used. And when we say echo, this might be echo heart, echo lung, echo abdomen. Echo is a repetition of sounds. But this is the echo heart. This is the short axis view. This is the long parasternal axis view. Again, another short axis, parasternal short axis view on zoomed view. What you can see is that the left ventricle is very hyperdynamic, almost empty. You see it here, kissing walls and kissing papillary muscles. You see here also the walls, the septum is approximating to kiss the posterior and inferior walls, and the leaflet, anterior mitral valve leaflet, hitting the septum. And you can see here in the middle that barely you see the aortic valve, and the LVOT passage is almost very narrowed due to hyperdynamic circulation. What is very important here is that you barely see the right ventricle outlet tract, very, very small, indicating that the RV is very small against PE. And if you go back to the parasternal short axis to look at the septum, the interventricular septum, don't forget that this lady is obese. The views are not maximum. But again, here is a practical point that when you see an obese patient, don't be obstructed from the beginning and you say that this will be difficult case, ultrasound here will not be of benefit. Why? Because the patient is obese. This is not a rule. A lot of patients who are obese has or have a good, very good views, by the way, for transthoracic echo or lung ultrasound or even abdominal ultrasound. This is not a rule to forbidden doing or attempt to do the ultrasonographic exam when you are dealing with obese patient. And this is one of the examples here. And we see a lot of patients who are obese with very good views, by the way. So provisionally, when I see this loop for somebody who is questioned to be a pulmonary embolism to explain the shock and severe respiratory failure, at least I wouldn't put it at the top of differential diagnosis. The question will be, the argument will be, does PE causes echo manifestations significant to be totally abnormal, and you have to exclude, is it good negative test? Of course, there is nothing is 100%. But don't tell me that if you are dealing with a shock patient and acute type 1 hypoxemic respiratory failure due to pulmonary embolism, both are due to pulmonary embolism, and you see the heart healthy or hyperdynamic like this, and the RV is empty like this, this is very, very, very unusual. If we continue to do the exam for the lady who is day 3 post-surgery in the floor, obese, with risk factor for pulmonary embolism, collapsed in the floor, shocked and in acute respiratory failure, and this is her bedside echocardiographic exam. Here you see the IVC, this is subcostal view. Here is the liver, and here is the right atrium, and a tube that comes across the liver, emptying into the right atrium, is definitely IVC. And as you can see here, this patient is tachypnic, sucking the blood from the IVC, labored breath. So it's not reliable at all to rely on IVC when you have a respiratory distress, spontaneously breathing patient. Why? Because the suck and aggressive intrathoracic pressure with inspiration would cause false collapse of the IVC. But here again, IVC, when it is less than 1 centimeter by eyeballing and collapses steady 100% to kissing walls of IVC, is a strong indicator whatever is co-founders present of this patient, like respiratory distress, like intra-abdominal hypertension, like whatever, will not cause this aggressive collapse of IVC and significant decrease of size of the IVC, i.e., the IVC of this patient loop here is probably due to a significant hypovolemia. So again, kissing the wall of the left ventricle, small RV, collapsing to 100% collapse, small IVC to less than 1 centimeter are indicator of severe hypovolemia on this patient. To make it more clear, the more I see on this patient, by the way, we are dealing with patient who needs to be stabilized. We should not forget this. Point of care ultrasound has to take its role, but in the context of clinical presentation and with the priority in mind, airway, breathing, circulation, and then you go and do full assessment clinically and then by point of care ultrasound. And point of care ultrasound, what I want to refer here, is as essential as the all other tools that you do to assess your patient. When you assess your patient, you need to have differential diagnosis, reach top differential diagnosis, put management plan. Again, the clinical context with this loops of bedside transthoracic echo pointing me toward severe vasoplegia, severe hypovolemia with this free abdomen that looks turbid, free fluid in the abdomen. All of these puzzles should refer to a picture of something not PE, but septic shock. But not only septic shock. If you use, and you have time, of course, you did this couple of views, and then you tell your team that I need to give liberal fluid here. Please prepare for me the vasopressor, norepinephrine. If the patient initially doesn't respond to 1 liter and there is no contraindication for continuing giving fluid, and there is evidence of tolerance to IV fluid, then you continue give IV fluid as the sepsis campaign guidelines said, 30 ml per kg, but take care that not every patient, as Dr. Mustafa just mentioned, not every patient like the other. There is no one size fits all. But everyone has his own tolerance to IV fluid, indication to IV fluid. If you look at here, when we put the M mode on the parasternal long axis at the tip of the mitral valve, you see in the M mode here, that the leaflet, the anterior mitral valve leaflet, reach the septum. Anterior mitral valve motion toward the septum is called SAM. When we open, as you see here on the three-chamber view, when you see the left atrium, left ventricle, mitral valve, aortic valve, LVOT, you put the cursor of the pulsed wave Doppler here, and then you have the typical shape of hyperdynamic LVOT obstruction due to sepsis. And the LVOT obstruction here is dramatic, killing. If misled, if misdiagnosed or missed in diagnosis, and this patient's circulation is not properly filled, or you use vasopressors, I'm going to come to some of points here are very important to mention, that significant proportion of septic shock patients, they develop intraventricularly or LVOT obstruction. So the left ventricle itself will have obstruction inside the left ventricle itself. When you put the cursor of pulsed wave Doppler, because of the kissing walls, you're going to see the obstruction inside the ventricle. And if you go down to the LVOT track just above the aortic valve in the picture, in the loop, and you fire the pulsed wave Doppler, you see this dragger-shaped wave of VTI, and this indicates very severe LVOT obstruction. This is common in septic shock. Again, when you start to fill this patient's circulation, you have to have evidence bedside that you are starting to fill the circulation. If you look at the IVC on the top left, your left here, you see this is at presentation. The IVC here is very small, collapsing to 100%. With bolus of IV fluid, 1 liter, the IVC started to be filled. Size is about above 1 at least centimeter, and the collapse is less than or around 50%. You started to see that the walls with the IV fluid started to not to approximate till it kiss each other. No, so the circulation started to fill. We started to see the right ventricle as well. And here you have to have evidence that my patient, as you see here in the previous short axis parasternal, we don't see even the papillary muscles or the intraventricular space. Here we started to see with bolus of IV fluid. What I meant by that, you have to fill but not to overfill the tank. So you don't see that this tank or this, let's say, glass, when it's full, should not be overfilled, because the overfilling will cause flooding of the circulation. And then you start to see extravascular volume inside the tissues of the lung, kidney, liver. And this is complicate the patient's outcome, of course. The positive balance in critically ill septic shock patients, when it's not necessarily, it increases the mortality and morbidity of septic shock. So what you need to do is to fill the circulation, not to overfill it, and to use early vasopressors, not to delay using the vasopressors, and everybody is toward this recommendation nowadays. Septic shock patients, they might present from the beginning with a left ventricle like what you see here in the middle, that is barely contracting, or in the short axis view here, like what you see here. This is the papillary muscles, this is the left ventricle, this is different walls, inferior, right, septal, lateral walls, and then you see hypokinesia globally. All the walls are globally hypokinetic. In a septic shock patients, this should be explained. And the only explanation for the global hypokinesia in septic shock patients, especially the young, you're going to be surprised that the young people have septic cardiomyopathy not as less frequent as the old patients with history of ischemic heart disease. Sepsis might be severe to cause multi-organ dysfunction. One of the multi-organ dysfunction is the cardiomyopathy, and we forget this. When you ask the donor fellows or trainees, what are the multi-organ failure, caused by sepsis or septic shock, they will mention everything, but they forget to mention the heart. A lot of things to indicate multi-organ failure on the heart. One of them is arrhythmia. One of them is cardiomyopathy. One of them is, it might be focal hypokinesia. Everything can happen on the heart because of sepsis. And this is one of devastating, very dramatic, devastating complications of septic shock. That again, it may present in up to 60% of septic shock patients. And after few hours of presentations, not 1 or 2 or 3 days, evidence is showing clearly that even after 6 hours, as Antoine Villard-Baron showed this in one of his literature, 18% of septic shock patients, 18%, let's say up to 20%, they developed septic cardiomyopathy in less than 6 hours of their presentation to emergency room. And it involved the septic cardiomyopathy, both systolic and diastolic function. The problem is here that when you leave patients without proper resuscitation and you leave the hypovolemia unrecognized, not dealt with as it needs to be dealt with, this induces diastolic hypovolemia is one of the common causes of this diastolic dysfunction if left untreated. And the unjudicious fluid resuscitation induces diastolic dysfunction. Tachycardia induces diastolic dysfunction, not only AF or flutter, but even the systolic, the sinus tachycardia induces, any tachycardia induces, because it shortens the diastolic time. So diastolic dysfunction is one of the complications, very well-known complication of all of these factors, plus the use of vasopressors, the use of inotropes, the stresses, everything might induce diastolic dysfunction. And this is very dramatic when you are dealing with sepsis or septic shock. This is another example with patient who presented with necrotizing pneumonia and necrotizing pancreatitis and severe sepsis. They presented in ER with this left ventricle. You see here the apical 4, sometimes it opened the apical 5. There is global hypokinesia. In the short axis, which is the best, if I choose one of the multiple views on the heart in critically ill patients to use and to comment on, I would give my money all to the parasternal short axis view at the level of papillary muscle. Why is this? Because I see different walls of the left ventricle. I can see and comment clearly on the left ventricle shape and volume size. I can see the right ventricle above the septum, which is a crescent-like shaped. I can see clearly and comment on the septum. Is it flattened or not flattened? So a lot of information. If I fire the M mode to evaluate the ejection fraction, the best site to evaluate the ejection fraction is at the level of the short axis. You fire the M mode in between the two papillary muscles. All of this. But as a golden rule, it's worthy to mention here that you never stop at one view. If you see one view and you see a lot of finding, don't stop here. And you comment and base your plan on this single view. Never. Try to see another view, third view, fourth view. If you are able to do the full study, the time allows you and the clinical condition allows you, go ahead and do everything possible before you decide. And again, believe me, it doesn't take much time. Not as people believe, or there are a lot of myths or a lot of misbeliefs the point of care that it is time consuming. It's a time consuming when you don't know what to do and how to do. And it's easy to know what to do and how to do it. This is very easy. As we learn, you can learn, anyone can learn. You have to have certain question in mind, and you have to target to answer these questions with a focused goal-directed exam. What I'm looking for in this clinical scenario, what I have to rule in or rule out. The questions are clear, the answer has to be clear. You do this view, you change it to another view, you see the third. Now I can comment on the 4 pillars or 5 pillars of the questions for anyone who is hemodynamically unstable or in respiratory failure or whatever it is. And again, as a rule, the most common reason for heart to fail is lung failure. And the most common reason for lung to fail is the heart failure. So majority of our patients in ICU, general or CCU, are sitting here. And the minority comes from the periphery, that the reason for the heart to fail from the abdomen, or the reason for the lung to fail is the kidney. So you start with your target of failure and you go to the periphery and you see where to go. All of these are easy to know. This is, I'm not gonna exceed more because I think I already exceeded half an hour. ودي ليلة فردية فمش عايزين نضيع على الناس كمان the good night of 25th of Ramadan إن شاء الله.
بس كده لازم هتدينا جلسة تانية بعد رمضان عشان تقول لنا
if you allow me to go with another 15 minutes.
احنا
Very
عايزين
good.
حالة كمان عشان احنا لسه دلوقتي عندنا وقت. ادينا
ماشي.
حالة كمان تلت ساعة
أو
وبعدين نبقى ندي جلسة
أو
تانية بعد رمضان. اتفضل.
أو اتنين إذا الوقت يسمح يعني.
ده ليه اسم حاجة.
Okay. One of the common scenarios that we see every now and then in ICU is one like this lady, 28-year-old, who came to our ICU post cesarean section. She was in her 34th week of pregnancy when she developed hypertension, proteinuria, and severe hypertension. Was not responding to magnesium, antihypertensive medications, and people started to be afraid that she might go to eclampsia. Then a decision was taken to deliver her by cesarean section. Post cesarean section in the room at the OR, she remained desaturating and requiring higher FiO2 to maintain her saturation. Then we were wondering why young lady with no past medical history is now in respiratory failure requiring high FiO2. We reached up to, we have to use the non-invasive ventilation, CPAP. So as I mentioned before, the most common reason for this lung to fail to maintain the oxygenation is cardiovascular failure. People, they forget this. And as well as you have to examine this patient's lung, you have to examine this patient's heart. And you have to be capable of seeing the heart, not to listen about the heart, because people, they like to listen about the heart. How they listen about the heart, the consultant or the senior will ask the junior, how's the heart rate? They would say, heart rate is less than 100. He will be satisfied. How is it sinus or not sinus? Do you hear any atypical sounds, murmurs on the heart? Do you hear the second heart sound splitted or not? Clinical signs are not sensitive, not specific. And the maximum sensitivity, to the best of my knowledge, for the heart sounds and murmur to discover the abnormality on the heart, either muscle or valves, doesn't exceed 20 to 25 or 30% sensitivity. And specificity is maybe around 40%. It's nonsense. I'm not saying that you ignore the clinical, no, at all. I'm not saying that you do not respect the history. No, no, at all. But the history and clinical sign might be deceiving. And the one which doesn't deceive you is that you see something with your eye. When you look to see something and you know how to see it, you see yes or no, then it's not gonna be at all deceiving. الرائد الذي لا يكذب أهله هو point of care ultrasound when it's used rightly. When it's used rightly. So when we put the probe on the heart, we immediately got the answer because we know, as the British people says, that I see what the brain knows. If you don't know, then your eye wouldn't see. We know that pregnancy and eclampsia or preeclampsia can induce cardiomyopathy. For a young female who doesn't have past medical history of any lung disease, the heart should be blamed first. And then you have to go with point of care, few focused, goal-directed exam. When you look at the apical 4 here, you would see that the left ventricle is not contracting well. Use your eyeballing to assess. This is in the apical 4. This is in the short axis parasternal at the level of papillary muscles. Globally, this is not what we see in normal, what's supposed to be stressed patients should be contracting more aggressively than this. Roughly, you have to see a reduction of the intraventricular size of more than 30% and thickening of different walls of more than 30% of their relaxing time, diastole time, thickness of the muscle. This is not the case here. The size of the left ventricle doesn't reduce significantly, and the wall's thickness of the muscle does not increase significantly in different parts, I would say globally. So we are probably dealing with a pulmonary edema due to a cardiomyopathy induced by this pregnancy or this stress or this hypertension due to preeclampsia or eclampsia, something that can be proved by numbers. If you see at the ejection fraction, with all limitations of the ejection fraction, at the level of between the papillary muscle and the short axis, the M mode was fired, and then the ejection fraction was calculated to be 45 or 40 plus percent here, reduced. And if you look at the Samson here, it's also reduced. When you look at the S wave in the tissue Doppler of the mitral valve leaflet, the medial one is less than 5 centimeter per second, which is significantly reduced. And the tissue Doppler is one of the sensitive and specific indicators of the systolic function. If you see the filling pressures are also here maintained more or less than 2. But again, when you look at the lung, you see effusion on the lung. This is the left side, this is the right side. And behind the effusion on the lung itself, you see a lot of B lines. If you see here the curtain sign, the pleura, and the B lines significantly so indicates that the lung of this lady was congested and the left ventricle systolic function is significantly impaired. Patient was shifted to ICU to properly manage her respiratory failure, which is due to cardiac failure, giving anti-failure medication. And this is the second day of giving her anti-failure medication. We could wean off totally the inotropes and even the CPAP and high oxygen. Now she is in minimal oxygen support. Look at the left ventricle contracting nicely. Short axis, you see significant reduction of the intraventricular space with every systole. And maybe we extensively diurese her, so we started to see papillary muscle approximating each other. If you compare before starting the anti-failure medications, you see the significant difference. Before, the anti-failure medication are on the top, after the medication in the bottom, you see the difference after 1 day of treatment. Why I'm saying this? Because the old people who are, I'm not meaning old, means old age, no, but the old school of management of ICU patients does not rely on point of care, but they rely on clinical sense, and they may rightly diagnose preeclampsia or hypertension or pregnancy-induced cardiomyopathy with history and clinical examination, with the help of cardiology, who comes day after to put the probe of echo to examine and maybe reach this diagnosis. Might take 1 or 2 days to reach a basic cardiologist to convince them to come to do echo for a young patient who doesn't have any past medical history of any heart disease. That's why we're saying that frontliner intensivists should be capable of dealing with 24/7 point of care ultrasound machine bedside, because they can diagnose, they can initiate management, they can repeat to do the effect of their management and modulate the management plan based on what they see with their eyes, because they see what's going on. You might have the cardiologist come day after you start the treatment and do the examination while the patient on this stage in the bottom here, and they would say this patient heart is normal. Why you start this or start that? If you are storing your study in the archive in ICU and you tell him or her, the cardiologist, come, my friend, and see. This is what we are doing every day. Come and see. This is before we started, let's say, for example, levosimendan, or we start the diuresis, or we start the beta blocker, or started any of anti-failure, approved anti-failure medications. And this is now. This is because of the anti-failure medication. So point of care, ladies and gentlemen, point of care ultrasound has its a significant role in ICU. And I'm not saying significant role that you can manage without. It's unavoidable. There is no excuse not to learn and to reach the satisfactory level of experience of how to use point of care ultrasound, because this is very beneficial to your patients. And believe me, and I have a lot of cases to show. It's my pleasure to accept the invitation, Dr. Hassan, for post-Eid, inshallah, another presentation. But the message that has to be delivered to the ladies and gentlemen here, that there is no excuse not to be capable of using the point of care. This my reach out data. If you want to reach out to me, I have number here in Egypt. I'm staying in Egypt since sometimes, where inshallah we have webinar on April 15. This webinar with figures, international figures, that we are working together for what we call it point of care ultrasound fellowship, point of care ultrasound in acute care setting. So whenever the acute patients are there, what should we learn to do for them? This is a fellowship for a year. It will be inshallah online, وفيها international speakers from everywhere in the world, وكلهم friend of mine, and I know their caliber in teaching and in giving materials. واحد منهم إن شاء الله 2-3 بيكونوا معانا في الويبينار، منهم دانيال ليشنشتاين. ودانيال ليشنشتاين is the father of lung ultrasound، أكيد حضراتكم تسمعوا عنه. وجريس واجينكو is American from originally من أفريقيا، من كينيا. Is a very good emergency professor، وعندها a lot of degrees in point of care ultrasound. ومعانا طبعا أكيد تسمعوا عن دكتور وليد الحبشي، اللي هو the founder and owner of the Saving Lives Academy, and a lot of courses were teaching in point of care ultrasound. معنا بروفيسور جاكوبو from Portugal وبروفيسور أولفا from Tunis. So this is on 15th، والبرنامج بتاع الفيلوشيب إن شاء الله يبدأ June 30، بس ده هيحتاج registration. وممكن دكتور حسن بالجمعيات المصرية يعني، ممكن الاورجنايزنج كومباني ممكن نكلمهم ان هم يعملوا جود ديسكاونت للناس اللي هي ان شاء الله من مصر، واذا في جروب ريجستريشن بنساعدهم ان شاء الله رب العالمين.
لكن
ثانك يو فيري ماتش.
ابريل 15 ده فري.
this is
ابريل
totally free.
15 ويبينار فري، واللينك فين؟ اللينك
بس
هتنزل بعد
سكان،
كده.
لا هو سكان تو ريجستر،
اه، اوكي اوكي.
وانا ابعتها على
ابعتها
هتلاقي.
عندي وانا احطها على موقع الاعلام بتاع الجورنال كلاب، كلهم
اه
بيشوفوها، عندنا 4 مواقع.
هتنزل بكره مع ال قول معايا كل
على كده.
الديتيلز. وممكن حضراتكم كمان تزوروا موقع الجمعيه دي او الانستتيوشن اللي هو World Institution of Critical Care and Emergency. It's American non-profit institution. ده العنوان بتاعها، في حد مشخبط على السكرين.
لا، دي من
فما
عندك.
ايوه
وانا
من
حاولت
عندنا،
الغيها ما عرفتش والله.
مم.
مش من عندي لا،
احيانا
لان انا
بتتلغي، لا مش من عندي، حاولت الغيها ما مش راضي تلغي حد كده،
معلش ده
بتبقى
مش
خطأ يعني.
ولا اي مشكله.
خلاص.
سعدت جدا جدا
احنا
بحضراتكم
متشكرين قوي، وهتوعدنا تقول جزء تاني بعد اسبوعين. احنا عندنا كل اسبوعين دلوقتي، بعد كل اسبوع.
بعد اسبوعين هيبقى ابريل كام؟
هيبقى 7.
عندنا ويبينار يوم 8 ابريل.
خلاص
في
نخليها
النيورو.
يوم. انت 15 برضو عندك، هتبقى 14 مشغول. خلاص هنخليها 21 ابريل ان شاء الله، حابب اكلمك.
21 ابريل كويس جدا ان شاء الله.
متشكرين جدا جدا. في حد بيطلب تحط على
قلنا
على
الكلاب
اللينك
يا دكتور، قول
بتاعته.
له يكتب التليفون
اكتب.
بتاعه واحنا ندخل.
لا، في حد طالب دلوقتي دكتورة
حد.
إسراء إنها
اه
تدخل على الجروب، حط لها اللينك لو سمحت.
ماشي يا باشا.
شاكرين أوي الدكتور أشرف، سهرناك
انا شاكر جدا 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 وسهرتكم انا.
لا، ده احنا مبسوطين. احنا طبعا في غير رمضان بنعمل يوم الاثنين بس، بنبتدي الساعة 9. من 9 9 ونص الفيلو أو المعيد، ومن 9 ونص ل 11 البروفيشنال سبيكر زي ساعتك. فده المواعيد بتبقى بدري عن كده شوية في غير رمضان أساس يعني. في رمضان قلنا.
وارجو ان يكون البرزنتيشن ما كانش فيها تقطيع ولا حاجه.
لا بالعكس، ده مفيدة جدا. وأنا يعني ما كنتش عارف لسه هم في شوية موجودين. أنا بؤيد اللي أنت بتقول عليه ده. وأنا عندي يعني خلال 20 سنة، بينهم 20 سنة حالتين، حالة من 20 سنة ستروك وبيحضروا تي بي اي لأن ما عندهاش اف وهايبرتنسف، وقالوا خلاص يبقى. فأنا قلت طب أما أعملها ايكو كده، لقيت ايه؟ رايت اترال ميكزوما. هي ايه؟ بتشاور.
يا
فطبعا
ساتر.
ادينا تي بي اي وبعدنا للجراح شالها، والكلام ده شيء بقى له 20 سنه وشيء سرفايفنج فيري ويل.
لوت
فالالترا
اوف
ساوند
كيسز والله يا دكتور.
غير التجنوز خالص. ومن
لوت
اسبوعين
اوف.
بقى حاله تانية. عيان عنده سيبسز في ركبته، وعنده دايريت كارنيوباثي، وفجأة جاله بالموني امبوليزم، سي في عليت، ورايت اترم كبر، ورايت فينتك ديسفانكشن، والبالموني هايبرتنشن، والدي دايمر عالي. فعلى طول جراح الأوعية، أنا هركب له فلتر يا عم. واحنا ما هو تلاقيه بقى من الرق ده والعظم ده والشغل. أنا دي في تي قلت برضه اما اعمل له ايكو، لقينا رايت فنتريكولار ثرومبس. الرايت فنتريكولار ثرومبس هي اللي بتشاور. قلت له هتركب بقى فلتر ليه؟ ده رايت
ربنا
فنتريكولار ثرومبس بتحدف على المنع على البلمونري.
اه.
ففعلا زي ما حضرتك بتقول يا دكتور اشرف، الالترا ساوند في الاي سي يو لازم يبقى فيه بورتابل الترا ساوند موجود 24 ساعة، ويكونوا أطباء الرعاية على دراية باستخدامه، لأنه ممكن يغير الكلينيكال دايجنوز. شاكرين.
واتوقع انه في بعض البلاد بدأوا يحطوها من الحاجات اللي انت لازم تحضر اجابة للسؤال في المحكمة لو اتسألت ليه ما
مم.
عملتلوش التراساوند بوينت اوف كير. لان انت هتخسر ايه لما تعملها، وهتكسب ايه لو لقيت حاجة. هتكسب سيفنج لايف. لسه كان واحد باعت لي من 3 ايام بالظبط، بيقول لي ويشكرني يعني لله الحمد والمنة طبعا، انه وهو عنده مريض داخل له الاي سي يو از نمونيا وريسبيراتوري فيلير، واتحط على نون انفيزيف ودلوقتي ديتريريتنج and he had to intubate him وبقى شوكت. فاحنا في الحالات اللي زي دي بنعمل ايه؟ الله ده كان اي ار دي اس وديتيريتد، فخلينا نحضر نديله بقى، وصل لسيفير اي ار دي اس، انتيوبيت هيم، برون بوزيشن هيم، حط له ستيرويد، كلم الجماعه بتوع الاكمو، تخش في كاسكيد معروف بتاع السيفير اي ار دي اس. طب هتخسر ايه لما تعمل ايكو؟ بقول عملت الايكو، واذا بي افاجئ بان كل اللي بيحصل ده من كابل اوف اورز فاتوا، لان الراجل ديتيريت بسرعه شديده جدا، حتى وهو في الفلور داخل عنه بكح وحراره ومش عارف ايه، قعد يوم deteriorated. لما deteriorated was not deteriorating because of ARDS، انما because of pulmonary embolism، والsigns are very dramatic. يعني كل حاجه بيقول عليها الكتاب، وهو اللي الناس لازم تفهمه وتعرفه، انه الله سبحانه وتعالى لما بيشوف في حد نية خير بيوفقه للخير. بتلاقي انت الحاجة بتقول لك انا اهو، وده اهو، والديسيجن اهو، بتلاقي نفسك internally وintensively رايح ناحية الديسيجن، وتحس كأن انت في حد بيزقك في الديسيجن. he thrombolized him، تاني يوم extubated and back to totally free person على minimum oxygen. انا have a lot of cases like this، a lot of cases. يعني ما اقدرش اقول لك حاله واثنين وثلاثه، لان I have a plan انه ما فيش مخلوق يدخل الاي سي يو الا في خلال ما يتيحه الوقت لازم يتعمل له بيت سايد بوينت اوف كير الترا ساوند، وهنا بتبقى جنرال مش بس هارت ولا لنج. يعني وبيليف مي it doesn't take in your hand، لما تبقى خلاص اتعودت ما بتاخدش معاك 5 minutes، والله اقل من الوقت اللي بتاخده عشان تحط سنترال لاين، عشان تقول قال ايه اقيس السنترال فينس بريشر، في حين ان انت عندك حاجات كتير اهم من انك تقيس السنترال فينس بريشر، وتقعد وتعقم وتتعقم وتحط لاين وتقعد بالساعه عشان تحضر لحاجه. وممكن انت بمجرد ما تحط البروب you see something that was not in your mind at all، وخسرت ايه لو لقيته فري؟ بالعكس ارتحت. بس
في واحد
شكرا.
عايز يسألك اسمه لينوفو، معرفش لينوفو دي اختصار ايه،
لينوفو
اتفضل.
ده نوع هو لو يغير اسمه، لان هو رحب
الج-
بيا برضه وانا برحب بيه.
الجهاز
لا
اللي
سوري،
داخل.
انا نسيت اغير اسمي. اكيد حضرتك فاكر صوتي.
الصوت جميل جدا وانا فاكره،
ده
بس مش
لازم
فاكر.
محمد فوزي.
صح كده.
اهلا حبيبي حبيبي، ازيك يا محمد؟
انا بس ليا تعقيب واحد على الكلام اللي بيقوله دكتور اشرف. ممكن اكون
لا انت
بدات
هتقول
معاه من
تعقيبين.
2000 لا ده مش تعقيب. يعني استحاله ان انا اعقب على حضرتك. انا
ربنا
بدات مع
يبارك لك.
حضرتك البدايه وانت بتمسك ايدي من 2012.
ما شاء الله.
تمام، بدانا مع بعض مشوار الالترا ساوند العسكري.
يا نعم.
وحاله من الحالات اللي حضرتك ديسكاس دلوقتي اللي هي بوست بارتم دي كارديوميوباثي اشتغلناها مع بعض.
يا سلام عليك، صحيح.
مظبوط.
بقالها كام
فيعني
سنين، كام
لغايه
سنين
دلوقتي ده
دي؟
الالترا ساوند ده في دمي من ساعه ما حضرتك علمته.
ربنا يبارك لك يا دكتور فوزي.
بجد يعني ده مش
انت
مجرد
انت
شكر
دلوقتي
لحضرتك
واحد من
بس.
الناس الجميله الانستراكتورز الممتازين في
الله يخليك يا
البوينت.
باشا، بفضل تعليم حضرتك.
بفضل الله يا حبيبي، ربنا يبارك لك.
الله
الالترا
يخليك يا
ساوند
باشا.
ينفع في السبونديلوزز اللي جاله ده في ظهره؟
لا
ينفع.
ينفع.
ينفع الدعاء في الليالي المفترجه، ربنا يشفيه ان شاء الله.
يلا الحمد لله رب العالمين. وكويس اني شفت
معلش.
حضرتك، وبجد بجد فكرتنا بايام الحلوه بتاعت حضرتك.
ربنا يكرمك يا دكتور محمد،
ولازم
تحياتي.
نكمل مع حضرتك ان شاء الله.
ان
وبجد
شاء
الرساله اللي
الله.
حضرتك قلتها دي ان لازم الالترا ساوند يبقى بدل السماعه، وبدل يبقى لايف اسسمنت في افري راوند.
صحيح. صحيح. كتر
سعداء
خيرك.
بكم جميعا،
الله
وهنترككم
يخليك
بقى
يا باشا.
عشان اللي عايز يصلي ويدعي
يلا.
النهارده أحد الليالي الفردية. وكل عام وأنتم بخير ورمضان
خير يا باشا.
كريم. شكرا يا دكتور
كل عام
سلام.
أشرف،
وانتم
تصبحوا
بخير.
على خير.
شكرا
شكرا،
جزيلا.
تصبحوا على خير.
نعم، مع السلامه.